Okay, so this is SOT protocol for Category 1. The first thing that we have to do is we're going to check for the short leg. We do this by examining the medial malleoli of either of her feet, and we see that she has a right short. We're going to file that away for later. Next thing that we do is we come up and we do our trap fiber analysis. Now there are 7 zones across her back. Number 1 originating just medial to her AC joint, and number 7 originating just lateral to the spinous process of T1. And we're going to go through and we're going to see if she experiences any tenderness or pain when we poke on these areas. So, painful?
No.
Tender?
No.
There?
No. 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 No.
Okay, so she is clear on her right. Now let's come across and try the left.
Yes.
Okay.
No. Yes. No. 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 No.
Okay, so we don't have to compare right versus left, but we do need to figure out which one of these two is the most tender. So, does number 1 bug you or number 3?
1.
Okay, so we know that number 1 is the most tender. Now this is going to correspond to either C1, T1, T2, or T10. So we're going to come in and we're going to put pressure on those specific vertebrae and see if any of them are tender. So is this guy tender?
No.
Okay. How about T1?
No.
T2?
Yes.
Okay. And T10?
No.
Okay. So because she does have an actual tender vertebra, what we're going to do is we're going to take a knife edge contact, brace with the other hand, and the line of drive is going to be inferior to superior with a little bit of a P to A, and we're going to get that back into position. Next thing we do is our heel tension. Now more often than not, this happens on the short leg as opposed to the long, and there are 3 ways that we can go about this. We can do this by distracting both feet at once, trying one against the other, or we can examine and palpate the Achilles tendon for tenderness. And so on palpation, I do see that her right leg is her right Achilles tendon rather, is more tense than the other. And so we go on next to our atlas dural subluxation. Now what's going to happen is, under normal circumstances, when she's laying prone like this, and she turns her head to either the right or the left, we should see when her head goes right, her right leg should go short. When her head goes left, her left leg should go short. And what we're checking for is the bump, so to speak. So if you could turn your head to the right for me. Turn your head to the left. One more time to the right. And to the left. So what I see is I feel movement in her right leg when her head goes right, but I don't feel movement when her head goes to the left. So there are 3 things that we have to do to take care of this. The first is that we go to the long leg and we distract this 3 times for about 5 to 10 seconds apiece with her head at neutral. And we would distract out and then release and do that 3 times. The next thing that we need to do is we need to go over to the short leg, and we need to do the same thing, except the patient is going to be rotating their head to the left and the right as we do so. So right and left, and we would do this 3 times, 5 to 10 seconds. And then the third thing that we do is we have her turn her head to the left, and we distract both feet at the same time. Again, 3 times, 5 to 10 seconds. So after we're done with that, we need to check our crest and our dollar signs. We do our crest sign by first examining with 2 fingers in an acute sense to see if we have acute pain. And we check for the muscle tone on either side of the erector spinae. And then we come in and we do our Davis compression, where we use a 4-finger contact, push the erector spinae together, and check to see which one has more tone, which one's wider, so to speak. So in this case, our left side is has more tone than her right, and so that's going to be a major crest on the left. And then we go to the dollar sign, where we're checking the muscle tone of her glutes. And it seems as though she has major signs on both, but we need to establish one or the other. So we're going to compress and look, and compress there, and compare the tone between the 2. And she has a major crest on the left. That's going to facilitate how we adjust when we block her. Now the way that we're going to block her, because she's a right short, we're going to flex the knee, externally rotate, and we're going to place this one under the greater trochanter, and this block is going to point superiorly. We then come across, do the same external rotation, and put this one under her ASIS pointing inferiorly, so that they do this. And then once we've done that, we have to adjust. And since she has major crest on the left, the first thing that we're going to do is we're going to do our glute scoop, our glute clap, by coming in, gripping the glute, and bringing the two together. The next thing that we do is we come across to the contralateral side, and we're going to do a PSIS toggle with a clockwise rotation. So it would be like so. Now that we have her blocked, we would have left her blocked for up to 10 minutes to allow the pelvis to realign itself. And we would have also made sure that before we left that her glutes were even, that her pelvis was even, and that her short leg did not go shorter, because that meant that we did something wrong and we'd have to reevaluate. So after we've done with the blocking and we have everything the way that we need it to be, the next thing that we do is our sacral base cough test. We take one of our thumbs, we place it at the lumbosacral junction about L5, and we ask the patient to cough. When she coughs, it goes straight to the ceiling, so that means that she is sacral base positive. The way that we correct for this is that we come across and we contact the sacral apex, hand pointing up, and we make sure to apply pressure along the curve of the bone itself as she inhales rather than exhales. So we're going to have her inhale, we're going to push against, and then as she exhales, we're going to release. We're going to do this 3 to 4 times until we feel as though the sacrum is cleared, the sacrum is released. After we've done that, the last thing that we need to do is our vasomotor test. So what we do here is we come across to all of these areas and we check every single spinous process in unison, and we find the one that's most tender. After we found the one that's most tender, anything in the lumbar or thoracic spine is going to have a corresponding cervical vertebra that's associated with it. We're going to put our fingers for palpatory purposes along the corresponding cervical vertebra, and then we're going to press against the thoracic or lumbar vertebra in question until we feel moisture attacking us up here, and then we know we've done our job. So we're going to come across, and you just tell me if any of these are tender.
That one's kind of tender.
Okay, that guy right there.
That one's more tender.
This one's more, okay.
No.
And the rest seems clear. So let's go back and find that one. It's here, right?
Mm-hmm.
Okay. So that looks to be about T7? Yeah, T7. And that corresponds with C5 up here. So I would go and I would put my hands across bilaterally across the articular pillar of C5. And once I have that, I would come back down to T7 and I would simply apply a pressure for 5 seconds and then release for 5 seconds. We're going to push superiorly, and we're going to do this until we feel the response in her cervical spine. And once we have done that, we have finished with category 1. So, the end.